According to the Defense and Veterans Brain Injury Center, between the year 2000 and 2015, roughly 339,462 military service members were diagnosed with traumatic brain injury, better known as TBI. So often people talk about the effects of traumatic brain injury or the consequences of PTSD as separate conditions, which they are, but for the person who is living with the dual diagnosis of TBI and PTSD, it can be very hard to separate them. Just as meteorologists predict the perfect storm when unusual and unprecedented conditions move in to create catastrophic atmospheric events, so can the combination of PTSD and TBI be overpowering and destructive for all in its path. The person with TBI and PTSD is living in a state unlike anything previously experienced in their lifetime. Trauma is a common cause of brain injury in the United States and is a significant public health problem. Traumatic brain injury can result in a variety of neuropsychiatric disturbances, ranging from subtle deficits to severe intellectual and emotional disturbances. TBI is the result of mechanical forces applied to the skull and transmitted to the brain. This may lead to focal or diffuse brain damage. Focal lesions often result from a direct blow to the head and include brain laceration, contusion, intracerebral hemorrhage, subarachnoid or subdural hemorrhage, and ischemic infarct. Contusion occurs directly beneath or contralateral to the side of impact. Diffuse brain injury also results from the differential motion of the brain inside the skull, causing a shearing effect and stretching of the axons. This can produce a wide spectrum of injuries, ranging from brief psychological disruption to widespread axonal tearing, called diffuse axonal injury. In addition to brain damage occurring at the time of the impact, secondary damage from several processes may occur during the recovery period. TBI is associated with a plethora of cognitive deficits, some of which are more common than others. They include impairment of arousal, attention, concentration, memory, language, and executive function. Loss of memory may be for both verbal and nonverbal skills. Disturbances of executive function include poor planning, organizing, sequencing, and set shifting, with impaired judgment or impulse control. Researchers have suggested that cognitive deficits can be divided into several groups or phases according to when they occur in relation to phases of TBI. The first phase, of loss of consciousness or coma, occurs soon after the injury. The second phase is characterized by a mixture of cognitive and behavioral abnormalities, such as agitation, confusion, disorientation, and an alteration in psychomotor activity. This period of time is associated with inability to recall events, sequence time, or learn new information. The third phase is characterized by permanent cognitive sequelae and includes problems with speed of information processing, attention and vigilance, short and long-term memory deficits, verbal and nonverbal deficits, and problems with executive functions as well as mental inflexibility. This phase has also been described as dementia due to head trauma. Treatment is multidisciplinary and includes pharmacotherapy, physical therapy, occupational therapy, recreation therapy, speech therapy, and vocational rehabilitation. Cognitive rehabilitation is also important, especially during the first 6 months after injury, and this involves techniques to retrain the patient in specific domains by providing a series of mental stimuli, tests, and activities. Dopaminergic medications or psychostimulants may improve deficits of sexual arousal, poor attention, concentration, and memory. Mood disorders associated with TBI have been reported in the medical literature for a number of years. Major depression occurs in approximately 25% of all patients diagnosed with a TBI. Feelings of loss, demoralization, and discouragement seen soon after injury are often followed by symptoms of persistent dysphoria. Fatigue, irritability, suicidal thoughts, disinterest, and insomnia are seen in a substantial number of patients anywhere between 6 months to 24 months or even longer after traumatic brain injury initially occurs. Psychological impairments in excess of the severity of injury and poor cooperation with rehabilitation are strong indicators of a persistent depressive disorder. The treatment of depression secondary to TBI is very similar to treatment of major depression disorder and includes antidepressants, psychostimulants, and electroconvulsive therapy, better known as ECT. ECT has been regarded as a highly effective mode of treatment for TBI injury patients refractory to antidepressants. It's important to remember that in TBI, mood disorders are commonly accompanied by problems and in other categories including cognitive, behavioral, and somatic. Treatment should attempt to address as many areas as possible and at the least not worsen any specific area. Mania after TBI is less common than depression, but much more common than in the general population. In fact, it's seen in about 9% of patients. Changes in mood, sleep, and activation may manifest as irritability, euphoria, insomnia, agitation, aggression, impulsivity, and even violent behaviors. Anxiety disorders are common in patients with TBI and range in frequency from 11% to 70%. All variants of anxiety disorders are seen, including generalized anxiety disorder, panic disorder, phobic disorders, post-traumatic stress disorder, and obsessive-compulsive disorder. TBI patients often experience persistent worry, tension, and fearfulness. 10% of TBI patients tend to have apathy without depression, and 60% have some degree of apathy and depression following TBI. Apathy refers to a syndrome of disinterest, disengagement, lack of motivation, and absence of emotional response to stimuli. The negative effect and cognitive deficits seen in patients with depression are not seen in patients with apathy. Apathy may be secondary to damage of the mesial frontal lobe of the brain. Treatment of neuropsychiatric sequelae of TBI is complicated, and it includes pharmacological therapy and rehabilitative interventions, which are equally important. Rehabilitation should begin on the day of the injury and continue until the patient is stable or has reached his or her pre-injury baseline. Rehabilitation is multifaceted, and it includes cognitive rehabilitation, behavioral treatment, social skills training, vocational training, individual therapy, group therapy, and family therapy. Patients with TBI are often referred to as the walking wounded because a number of them have persistent neuropsychiatric sequelae even though they appear physically normal. They are indeed disabled personally, socially, and occupationally. Ideally, treatment of these patients should involve a multidisciplinary approach with a neuropsychiatrist working in close collaboration with the patient, family, neurologist, neurosurgeon, physiatrist, social worker, and the staff of community groups such as the local chapter of the Brain Injury Association.